Dear colleagues, in this video presentation we are going to present an interesting case of cervical formation resulting from a suspected myoma in expulsion. During the ultrasound examination, we will focus on the findings useful for making an ultrasound differential diagnosis between a myoma in expulsion and an endocervical polyp. The patient in question presents to the outpatient clinic, reporting a history of abnormal bleeding along with mild pelvic pain. She notes that these symptoms have worsened since entering menopause and are especially pronounced following intercourse. On transabdominal ultrasound examination, the cervical canal appears occupied by a formation of about 28 millimeters, with little vascularization. We are now continuing the examination with a more detailed assessment focused specifically on the uterine structures. First, we are evaluating the endometrial thickness. The endometrium, which is the inner lining of the uterus, appears to be quite thin based on our measurements. This is a key observation that will be documented and considered as part of the overall clinical picture. Next, our focus shifts to the myometrial study, which is an examination of the muscular wall of the uterus itself. A particularly critical part of this stage is the precise measurement of the cervical neoplasm. To fully characterize its size and extent, we are systematically measuring it in 3 dimensions. Right now, we are capturing the transverse dimension to determine its width. Now that the detailed uterine assessment is complete, the evaluation proceeds to the next phase, a transabdominal study designed to visualize the ovaries. This approach gives us a clear and comprehensive view of the adnexal regions. Upon careful inspection of both ovaries, the findings are reassuring. They appear bilaterally normal, which means that we are not detecting any significant structural abnormalities on either side. Furthermore, their echogenicity, that is, the way they reflect the ultrasound waves, is consistent with that of healthy ovarian tissue, which suggests there are no suspicious masses or cysts present. The expulsion of a myoma, also known as a fibroid expulsion, is a medical event triggered by the presence of submucosal uterine fibroids that are actively expelled through strong uterine contractile activity, and as a result, this process can cause significant pain symptoms. It is important to note that this is a relatively occasional event that is more prevalent in women of reproductive age with a fibromatous uterus. The cervical polyp, on the other hand, is an almost always benign type of formation that is quite often symptomatic. Its overall incidence can vary from 2 to 10% of women, especially during the perimenopausal period of their lives. Following the initial phase of the procedure, the examination then continues with a transvaginal approach, which is performed after the patient has completely emptied her bladder, a necessary step to ensure the clearest possible imaging. The patient being examined is a 44-year-old woman who is currently in the perimenopausal period of her life. The reason for this specific approach is that it allows for a significantly more detailed and closer look at the specific dimensions and size of the cervical neoplasm, which is an abnormal growth of tissue on the cervix. In addition to its size, a thorough assessment is also made of the growth's blood supply, known as its vascularization, with findings indicating that it is predominantly external to the formation. Based on our detailed analysis of the blood flow, which registered a peak systolic velocity of 4 centimeters per second, we can therefore confidently state that the observed formation is correctly assigned a color score of 1, a value that typically signifies minimal vascularity. In addition, it is critically important to emphasize the complete absence of any detectable internal vascularization within the main body of the lesion. Upon clinical examination, the endocervix, which is the canal of the cervix, is observed to be essentially linear in its structure. This finding is a significant indicator that the condition is a benign lesion, meaning it is not cancerous, and this diagnostic hypothesis is further substantiated by the negative results of the patient's recent pap test. The clinical observation of a significantly gaping endocervical cavity is also a strong indicator of a myoma in the process of expulsion, a diagnosis which is further corroborated by the specific symptoms the patient has reported. The examination continues with the ultrasound, which reveals a uterus that is not particularly fibromatous, but it does present with the very typical finding of what is known as an axe blow appearance that deforms the endometrial lining, a characteristic commonly seen in cases of a previous caesarean section. Therefore, to conclude, the correct and appropriate management of the case involves performing a speculum examination to properly visualize the external cervical OS in order to determine, for example, whether a polyp or some other mass is protruding from the external os, or to clearly assess the full extent of any myoma in the process of expulsion. The subsequent ultrasound is considered necessary for a correct and thorough assessment of the clinical case in order to more clearly understand and differentiate whether the finding is more likely a polyp or a myoma. Following this, it is important that proper and detailed counseling with the patient is conducted so that it is possible to perform a hysteroscopy with a complete histopathological examination of the biopsied lesion, thereby completing the entire diagnostic process. Thank you for listening.